On the rapidly evolving field of oncoanesthesia, a specialty that brings together surgical complexity, physiological stress, and a long-term oncological outcomes. To chair this important session, we now invite Dr. Suresh Y.V., Professor, KMC Mangalore, Dr. Mallikarjun H., Director, Lakeview Hospital, Belgavi. Our first speaker for this session is Dr. V. Arun, Senior Consultant and Lead Anesthesia and Pain Management at Aster CMI Hospitals, Bangalore. Please join me in welcoming Dr. Arun for his talk, HIPEC, Cooking Cancer in the OR.
Good afternoon. At the onset, I'd like to thank the organizers for asking me to give this talk. Cooking cancers in the OR. Now, this is a post-lunch session. I think most of us have done our cooking and are ready to sleep. And I'd rather have that in the OR rather than cooking cancer. Now, in terms of cooking cancer or HIPEC, it's something which is starting to take up off late. There are quite a few hospitals which are starting to do it, and some of them are doing it more frequently. We've been doing it quite frequently for the last 2.5 years. We've done more than about 200 odd cases of HIPEC. Now the question is, how do you manage these patients? First of all, why should you be doing HIPEC, and then how do you actually manage these patients? Peritoneal surface malignancies are one of the growing field of surgical oncology, which surgeons would like to treat aggressively because there is no other alternatives available for them. Most of them are secondaries from ovarian or GI or stomach cancers or pseudomyxoma peritonei, which do not respond to traditional chemotherapy that well. They don't respond to radiotherapy. So you're looking at alternative options of trying to treat them, and surgical treatment is probably one of the best ones. So you're looking for trying to treat all the seeding which goes on in the peritoneal cavity with these patients. Now, the whole surgery is in two parts. One is cytoreductive surgery. That is, you take out as much as possible in terms of gross tumor. And the second part is the HIPEC, which is the high temperature intraperitoneal chemotherapy. Now, you have to remember this is meant for microscopic peritoneal disease. It's not meant for gross disease. And it tends to penetrate only about 1 or 2 millimeters inside the abdominal cavity. Now, that roughly tells you that abdominal tumors, especially from things like ovary, they would spread both to the liver, to the diaphragm, because of respiratory mechanisms, because the seeding moves across, ascites. You have bowel peristalsis, which actually moves it. So this is all seeded all throughout the peritoneum, rather than just one area. Goes to the lesser sac, the mesentery, everywhere. Now, they are trying to remove all of this and then treat it with high temperature chemotherapy, which is the problem. Now, if you look at microscopic disease, it's something which you will not be able to see with naked eye. You're just hoping that you increase the temperature and try and treat these. Now, why does it work? It's a combination of temperature and the chemotherapeutic agent. As you increase the temperature, the drug uptake into the malignant cells is better. So the surface cells which are on the peritoneal surface take up the chemotherapy better. They tend to increase tissue penetration. A temperature-dependent action of the chemotherapy drug improves, and there is inhibition of repair mechanism. Also, there is an altered cellular metabolism of the drug and drug pharmacokinetics. All this in total helps in achieving chemotherapy locally rather than giving the patient systemic chemotherapy and chemotherapy toxicity. So this works best at around temperatures of 39 or 40 degrees centigrade. So you're looking at abdomen which is being heated up to about 40 degrees centigrade, and you're leaving that abdominal cavity like that for the next probably half an hour to 90 minutes. Now, what temperature is best? So if you leave the surgeons go, they'll heat it up to 45 degrees. Higher the better is what they will say. But synergism is probably starts at 39 and ends at about 43 degrees. Other thing which you have to remember is if you start heating up bowel tends to have problems at about 42 degrees and bowel toxicity increases. The reason surgeons will not go further as well is bowel ischemia and bowel perforation actually increases beyond 43. So you're looking at a narrow range of about 39 to 42 degrees centigrade where the chemotherapy agent is being given intra-abdominally. Now, current evidence suggests that it's good for things like pseudomyxoma, peritoneal and pleural mesotheliomas, ovarian tumors with peritoneal deposits, colorectal tumors with deposit, and gastric tumors with limited PCIs. And there is some issue in terms of trying to push the boundaries, especially in gastric tumors and neuroendocrine tumors. And it's also under, people are also looking at it for sarcomas and GIST and small round cell tumors. So you can be rest assured that this is going to be a growing subject. More and more surgeons are going to be doing it. And you're going to get these patients on table. They're not small surgeries, they are major surgeries going on for a very long period of time. So that's been the history of CRS and HIPEC. Started in somewhere around 79 for the first pseudomyxoma, subsequently has been going up. And now we even do limited exploration and lap HIPECs. So you can have lap and robotic HIPECs as well now. Medial survival has gone up to about 24 months and the mortality rate's also been going down. So CRS, the part one of it, means that you have to take out the tumor bulk. That involves an arduous about 4 hours or 5 hours of surgery where they're trying to strip the whole peritoneal cavity out. They're trying to resect bowel. They're trying to take out the ovarian tumor. Extensive stripping may include splenectomy, may include a bit of liver resection as well. So you're looking at surgeries which are going on for a good 4 to 5 hours before the HIPEC even starts. So that's the abdomen. You'll end up finding that they remove almost bucket loads of tumor out from the abdominal cavity. This is almost a standard. A pseudomyxoma, if you see, they will remove some 2 or 3 loads of pseudomyxoma out of the abdominal cavity over a period of 4 hours. Now, subsequently, you cover up the abdomen and you start heating it up. Now, remember, you've had a major surgery on a sick patient going for 4 to 5 hours, and then you're heating the abdomen to about 42 degrees centigrade. That's the temperature which we would never ever heat our patients up to. And this goes on for the next 60 to 90 minutes. So 1 to 1.5 hours, you're actually warming up the patient to about 42 degrees centigrade. So these are issues which actually trouble the anesthetist more than anything else. And nowadays they have much more advanced machines. You have something like almost like a dialysis unit which sits inside the operating theater and heats up the abdomen and then keeps it running for the next 90 minutes. Now this is a robotic patient who's had closed HIPEC done. If you see, only the tubes are left behind, luckily. It's not an open abdomen, and then you see it running onto a CRS HIPEC machine, which will run for the next 90 minutes, and you would be giving chemotherapy through that. Now, anesthetic implications for a CRS HIPEC are significant. They're not for the faint-hearted, and they do take a lot of time and strain to do it. Now, primarily, you have to remember temperature goes up. During the CRS, the patient loses a lot of temperature. You might have your temperature dipping down to about 35, 34 because of an open abdomen, loss of temperature, loss of tissue. This causes a significant amount of bleeding, wound infections later on. During the HIPEC phase, this turns around from 34 degrees and goes up all the way up to about 40 degrees. So you're seeing a lot of temperature variations during that process. An increase in oxygen consumption, increase in cardiac output, increase in heart rates, and patients going acidotic. The increased abdominal pressure also causes lung issues, reduces your FRC, and reduces your splanchnic circulation. Any reduction in splanchnic circulation means lactates going up. So it's a drug and a process which is affecting almost every part of the organ system. Cardiac function takes a huge hit. Patients vasodilated, they are hyperdynamic in terms of their cardiovascular state. Blood pressure goes down significantly. You're looking at a lot of inotropes to use, and you're looking at a very high cardiac rate. Now, I heard all about using beta blockers, if you should have this or not. We frequently use beta blockers. We frequently end up having to do it because of the hyperdynamic state of the patient. Blood loss and fluid loss is another problem, especially when it's an open CRS. You're looking at about 4 to 5 liters of blood fluid loss from the abdomen, and another liter or 2 of blood loss if you have had a very bloody day. So fluid turnover is significant. Coagulopathies are very common. And then kicks in your chemotherapeutic agents toxicities. Renal and pulmonary issues are immediate, cardiac issues are immediate. Other things like neuropathy are quite late in onset, so you don't really have to bother about them during the case. Electrolyte imbalances is something which we do have to worry about throughout the case. Now, typically, most of our patients have a risk stratification of ASA 3 or 4. You do not get patients less than that ASA status for CRS HIPEC. And as per international standards, what they had looked at, almost everybody had standard panels of CBC, renal panel, LFTs done. Ours also is pretty much the same. Cardiac evaluation, internationally, people tend not to do echoes. They think that if the exercise tolerance is good, they don't tend to do echoes. But ours, we tend to do echo on not almost, everybody who goes through a CRS HIPEC. And occasionally the stress test as well, whether it's a dovitamin stress or it's a TMT. TMT patients are not able to do it. Usually it ends up being a dovitamin stress echo because we just need to find out how much we can put that patient through. PFTs again is dependent on the age, the kind of disease, and how much of intra-abdominal pressure we think exists prior to the surgery. All of them go through some standard orders, things like incentive spirometry, counseling about the duration of surgery, counseling about the ICU stay, and counseling about prehabilitation. Now, prior to bringing them on table, yes, we do try to have a little bit of prehabilitation as much as possible for oncology patients. Nutritional support, physiotherapy. Some things are correctable, things like anemia. We do tend to give iron infusions, no blood transfusions, but iron infusions definitely. Hypoalbuminemia, again, through nutrition rather than giving albumin transfusions, unless the patient is really sick. They usually, all of them get some amount of anticoagulations the day before because they're immobile and malignancy makes them hypercoagulable. Long-term survival intraoperatively, people have looked at this. There has always been this debate about inhalational versus TIVA. Morning I was talking about desflurane. Here I'll say TIVA is a little bit better than desflurane. You have to remember you have to take each case by what it does. They looked at about 11,000 odd patients. They realized that TIVA mortality rate is about 13.6%, whereas inhalational mortality is about 24%. So yes, TIVA probably plays a better role in oncology, and because inhalational actually reduces the killer cell activity, so TIVA probably is better. They looked at it in different forms, in overall picture, or whether it was in patients with metastasis, or in patients with ASA higher grades. Everywhere, TIVA did slightly better than inhalational in terms of overall mortality figures. Now, intraoperatively, all our patients get an epidural. Well, when I say all, almost 95, 96% of the patients get epidural. Very rarely they do not. It's in terms of best practice, yes, EJSO has said that thoracic epidural is much better, reduces complication rates, increases relapse-free periods as well. So our patients get at about T4 to T8, they get a thoracic epidural, awake preferably, and it runs with usually morphine intraoperatively and bupivacaine fentanyl postoperatively. It's very rare that we send out a patient only on a PCA or erector spinae blocks. We used to do them, but we very rarely send them out on these at the moment. Monitoring, yes, almost all of them have invasive monitoring, arterial lines, central lines. Frequently cardiac output monitors, especially the flow track. We tend to use it on high-risk patients where we think hemodynamic instability is going to be more, or the poorly controlled patients. Respiratory-wise, the standard respiratory monitors for most of them. Temperature is a must for these patients. Frequent electrolytes, ABGs intraoperatively, and sugars as well. I'll come to the sugars in a little while. Coagulation parameters, we don't tend to do PT, APTT, INR that frequently. We tend to do TEG, where as and when needed, we tend to do TEG intraoperatively. It's much easier for us, and it gives us results much faster. And almost all of our patients have a BIS monitoring or a nerve stimulator monitoring and urine output monitoring. Intraoperatively, fluid is one thing which you have to think about. Maintain a map of at least about 70 with a good urine output during the CRS phase. During the HIPEC phase, actually you need to maintain a slightly higher urine output. We almost double the urine output which is coming during the CRS phase. Post-HIPEC, again, you're looking at goal-directed fluids, correcting all the acidosis, hypokalemia, and hypomagnesemia. These are frequent findings in these patients, and you end up going. Typically, as a goal-directed therapy, you would try to minimize your IV fluids and maximize your perfusion pressures. Temperature during CRS is the warm phase where you try and keep the patient warm. They lose a lot of temperature. But 1 hour or half an hour prior to the HIPEC phase, you try and start cooling them down to at least about 35 degrees instead of the 37 degrees. During HIPEC, if you need, you can use cold lavages, cold fluids, but we don't tend to find that we need them. Just a couple of slides. Post-HIPEC, again, fluid warmers are essential. We've not seen significant temperature changes if we manage to maintain them at around 35 to 37 degrees. Chemotherapy, the primary problem with chemotherapy is AKI. Almost 37 to 40% of the patients have AKI post-CRS HIPEC, and the cisplatin is the primary reason why they have. So you have to maintain euvolemia, maintain perfusion pressures. In the last year, we've started using a lot of sodium thiosulfate, and there is trend to say that sodium thiosulfate reduces AKI on its own. Whether you add any other drug to it or not, sodium thiosulfate helps in protecting from AKI post-HIPEC. So we tend to do that. We do not do dopamine or furosemide or mannitol. Electrolyte imbalances, as and when they come, you end up having to manage them. Emergence, previously it's been looked at whether you extubate the patients or you do not, or you ventilate them post-op. Most of the HIPEC trials show almost about 50% of them are ventilated. In our series, what we do, almost 90% of our patients are extubated on table. Even if it's a 12-hour or a 13-hour or 14-hour surgery, they're extubated on table because we find post-op management is much better with these patients if they're extubated on table. This is something which we forget as anesthetists, to take care that the chemotherapy agents are actually discarded properly. It's kept safely in the OR and discarded and incinerated properly. I think that is essential if you're starting a HIPEC unit. Post-operative care is an extension of intra-op care, plus a couple of things: DVT prophylaxis, a very good thoracic epidural to be running for the next 3 to 4 days. You have to remember, for the first 72 hours, the patients become coagulopathic, so removing an epidural might be difficult for the first 72 hours. So you usually wait for the 4th or 5th day when the coagulation comes back to normal to remove the epidural. In summary, cooking is only part of the process. Prehabilitation is what takes care of most of our problems. Optimizing comorbidities is essential. And intraoperatively, it's fluid, electrolytes, temperature, standard things, but much more intensively. Extubate them early with good analgesia, and make sure you continue the same in the intensive care unit. Optimum communication with all the teams on when and how much of HIPEC to do is essential so that you don't overcook these patients. I would like to have that coffee every day, but unfortunately, HIPECs don't let you do that. Thank you.
Thank you, sir, for that fascinating presentation on the complexities of cytoreductive surgery and HIPEC.
Our next speaker is Dr. R.